बिस्मिल्लाहिर्रहमानिर्रहीम। अस्सलाम वालेकुम। वो मैं लाहौर में पैदा हुआ तो बचपन में सुनते थे एक आवाज़ लगा दो जागते रहो, मैं भी जगा दूँ ना, सोइएगा ना जाग जाइए। And it's an honor that I am presenting this talk in presence of such distinguished personalities sitting here who are themselves experts in diabetes, and many of you sitting here, the faces I recognize, are themselves experts in diabetes. So it's really an august gathering to talk about this topic. Claps to PSIM. Being a member of the other societies as well, you've outnumbered all the societies in Pakistan. So congratulations. Well, coming to my topic, I define diabetes mellitus now as a metabolic syndrome which is due to relative or absolute deficiency of insulin with or without insulin resistance, almost always associated with obesity. Why I am saying almost always? There are about 10% of people who may not be obese, with obviously its metabolic consequences, the inflammatory, the glycosylated, and obviously the metabolic effects which lead to its dire complications of macropathy and obviously microvascular diseases. So it's a complex disorder. It's not just simple hyperglycemia. So I am going to today talk about certain important things. And why talk about diabetes? Well, you can imagine. These are the worldwide figures. But just to praise you what's happening in Pakistan, I'm proud to say that Bakai Institute in Karachi with other institutes held a survey, and what did they find out? 1/4 of the 240 million population of Pakistan is diabetic. 1/4. It's 60 million people. And what they found out was that another 1/4 of that is in either metabolic syndrome or pre-diabetes phase. Oh my God. So out of 240, 120 million, half of them are already diabetic and half are going to be diabetics. For a country like ours, that's a huge burden. Half of the population. So we need to not only know about this disease, how to treat it, how to address it, but take measures to stop the progression and make people aware about diabetes. And I'm glad and proud to be on this forum where Dr. Zaman Sheikh Sahab held a very prolonged and very good session on awareness of diabetes and treatment of diabetes. So moving on, it has a number of risk factors. I briefly touched them. If you are obese or overweight, you are likely to get diabetes mellitus. Age is an important factor as well. With the advancing age, you are more likely to get diabetes. More so in the Southeast Asians who develop diabetes at a younger age as compared to the Caucasian or the white population who develop at a later age. So we unfortunately are more at risk. Family history. If one of your first degree relative is diabetic, your chances of becoming or getting diabetes mellitus is threefold increased. Threefold. And again, coming back to ethnicity, again belonging to South Asian population makes you more prone to become a diabetic. And we just had a talk on hypertension. If you are hypertensive, you 2.5%, 2.5 times more to get likely to get diabetes. So ethnicity, weight, your family history, obviously your age, and if you have diabetes, if you have hypertension, they all are going to contribute to make you become diabetic. And to make you more aware of the challenge of diabetes, diabetes is the 9th major cause of death worldwide. And 27% of patients with type 2 diabetes, in spite of all the treatments available, have macrovascular complications. 54% of them have microvascular complications. And out of that is 1/4, 25% of them have kidney disease. So you see, we have a huge burden of this disease in terms of complications, morbidity and mortality. I'm going to talk a little bit about the ominous octet. And what is that ominous octet? Once in the pathophysiology of diabetes, there is obviously decreased insulin production by the beta cells as they die out, waste out and dysfunction. There is increased production from the liver by gluconeogenesis and glycogenolysis. There is increased lipolysis, and there is obviously impaired hepatic appetite mechanism regulation. People tend to eat more. There is increase as the beta cells function less, the alpha cells start producing more. So there is more glucagon present in the blood and its consequent effects. There is increased glucose reabsorption. Normally, a normal person does not pass any glucose in the urine because it's so avidly absorbed from the kidneys. But in diabetic patients, the threshold of reabsorption, it becomes much more raised. For example, if I say cutoff is 180 milligram, when urine would show some glucose, in diabetic patients, especially the type 2 diabetics, which I'm talking about today, the threshold rises to 240 or 250. So they reabsorb more glucose. And why so? We'll talk about it just in a few moments. The SGLT2 is upregulated and they reabsorb more glucose, and that is one of the causes of glomerulosclerosis which happens in type 2 diabetic patients. And to top of that, there is obviously decreased peripheral utilization, decreased uptake of glucose in the peripheral tissue, and decreased incretin effect, which is my topic today. So what are incretins? When we take a meal, the L cells in the ileum, they secrete a amide which is called GLP and GIP, which are 736 amides, and they are released into the bloodstream, but they're acted upon by an enzyme called DPP4, dipeptidase peptidase inhibitor, which breaks it down to 936, and it has a very short half-life that is less than a minute, that's or 40 seconds, and it vanishes. But it has a very important role to play in the homeostasis of glucose in our system. Why so? This is the point. So, you see, normally we've got, this is the beta cell. We've got receptors, various receptors, but GLP has a uniquely different receptor present on the beta cell. And mind you, GLP does not attach to this receptor unless your blood glucose goes below 5 millimoles or roughly around 90 milligrams. So it does not attach to the beta cell. It only attaches to the beta cell at this receptor when your blood glucose falls down to less than 90. And then it obviously has its own mechanism of activating cyclic AMP and producing more proinsulin and leading to insulin formation and its release. So these cells are activated. Obviously, this, what I put up there is the mechanism in which the beta cells and alpha cells are stimulated in the pancreas. There are neural and nutrient effects, and obviously the two incretins, that is GIP, the glucose-dependent insulinotropic polypeptide, and GLP-1, the glucagon-like peptide. They have a unique effect. One hand on the beta cell, they cause more insulin to come out, and obviously I'll talk about how they preserve the beta cell as well. On the other hand, they suppress the alpha cells which are producing more glucagon. So why are incretins so important? Look at the black line. Look on the right side of this graph over here. The black line is showing obviously oral glucose, and the gray line showing the IV glucose. So what happens when you give IV glucose? The insulin response is not that dramatic. But when you take an oral meal, because of the incretins, because of the GLP-1 and the GIP, there is a tremendous surge in the insulin level, which maintains the normal homeostasis of glucose metabolism in our body. If we lose this surge, obviously we're going to be in trouble. And that's what happens in type 2 diabetics. So we do not have these GLP receptors only in the ileum, but we have got them in the brain, the myocardium, we've got them in the lungs, we've got them in the pancreas, and the gut, and the kidneys. So all these receptors are important. So it's not only the pancreas. These receptors also express the, obviously these sites also express the receptors for GLP-1. And why they become important, I'll soon talk about it. In the brain, if these receptors are attached to, they increase satiety and suppress your appetite. In the liver, they decrease gluconeogenesis and increase glycogen storage. In the kidneys, they cause natriuresis, and obviously I don't need to explain what will happen to the blood pressure. And in the heart, they increase the pumping of the heart and the contractility, and obviously the good effect of the heart is obvious. Blood vessels, they reduce the obviously vasoconstriction by causing endothelium-derived vasodilators, and obviously they decrease the markers of atherosclerosis, the inflammatory markers. Adipose tissue increase lipolysis. Skeletal muscle, we know there is decreased uptake in the skeletal muscles. So what do these receptors do? If they're attached to, they'll increase the uptake in the peripheral tissue. What about the beta cells? We've already talked about it. That the key is in glucagon, the increased production of insulin, increased biosynthesis of insulin. Not only insulin is released more, but we are making new insulin. And at the gut level, reduce mortality. So it will reduce motility. So if my appetite is suppressed, my gut motility is reduced, and I have natriuresis, my skeletal muscles, they start taking up insulin, or they start taking up glucose, the utilization is increased, and obviously the glucose stops producing new glucose by gluconeogenesis. All these mechanisms are the key to the control of diabetes, which are affected in type 2 diabetes mellitus. Now what happens in type 2 diabetes? This important incretin effect is lost. So again, this black line representing the oral glucose and the grey line representing the IV glucose. You can see in a normal subject there is a surge. This incretin effect, when it's lost, this surge does not occur. So that's why there is a rise in postprandial glucose levels and a general rise in blood glucose. So that led to the discovery. People thought about, what about if we inhibit the DPP4s? Wonderful. So we got the gliptins. They have beautiful effect of increasing the insulin, reducing the glucagon, and obviously what they do is by inhibiting DPP4, they increase the physiological GLP-1 and it stays longer in the blood and has effects. But unfortunately, it does not attach to other receptors that's in the brain or in the kidney or in the lungs or the heart. So the GLP-1 receptor agonists were brought in and they have added benefits. They not only act at the brain to cause suppression of appetite, but delay the gastric emptying and causing very important thing, that is the weight loss. So if you lose weight, you know everything comes down, your blood pressure, your glucose comes down, your well-being comes back, you become motivated to walk more and obviously exercise more. So along with the effects which DPP4 inhibitors are giving. So advantages of GLP-1 receptor agonist is not only a significant reduction in HbA1c, but significant weight loss, and they have a low risk of hypoglycemia. And why so? I explained in that cartoon which I showed where the GLP-1 receptor is and when it attaches to the receptor. Only when the blood glucose is, please speak up something that I get to know that you are listening to me. Less than 90. Otherwise it will not attach to the GLP receptor on the beta cell. So we have a number of approved GLP-1 receptor agonists, and we can see exenatide, which came first, has a half-life of 2.4 hours with a time to maximal effect in about half an hour. It has to be given twice daily. Lixisenatide, half-life 3 hours, time to maximum 1 in 3.5 hours. Liraglutide once daily, has to be given subcutaneously. 13 hours half-life and time to maximal effect 8 to 12 hours. Tulaglutide, it has a half-life of 4 days and time to reach maximal effect is about 24 to 48 hours. Semaglutide once weekly, half-life approximately 1 weekly, 7 days, and it reaches its maximal effect in 1 to 3 days. So that's why I choose to talk about semaglutide. It's coming in, it's already been approved by FDA and by European Union. This is a very simplified pathway to tell you about the treatment of diabetes mellitus. Monotherapy, we know metformin, but if you are at risk of ASCVD, you have CKD, you have heart failure, the ADA and ESD consensus guidelines, they say start with GLP-1 receptor agonist or SGLT2 inhibitors. Or if someone is intolerable of metformin, you go to these drugs immediately. Keep in mind, in these patients, the HbA1c is not going to be the routine less than 7 or 6.5 ACE levels. Is individualized. Because many of the studies told us, advanced, I can quote number of other studies as well, that tighter control in these patients leads to more morbidity and mortality. So we may be aiming for slightly higher HbA1c, maybe 7.5 to 8 or so. So it's individualized target in these patients. And when choosing second line for add-on therapy to first line drugs, keep in mind that weight gain, hypoglycemia, and the cost of the drugs. So little bit about once weekly semaglutide. It has 94% homology to human GLP-1 and a pharmacokinetic profile which is exactly suitable for once daily subcutaneous injection. Semaglutide, it causes increased insulin secretion, but also it causes beta cell responsiveness. The beta cells which are dysfunctional, it wakes them up. And like I'm trying to wake you up by shaking my hands, wake up, wake up. So it tries to wake up those cells to produce more insulin. It increases the postprandial glucose and obviously suppresses glucagon. Bile section at the brain and the gut, slowing the motility of the gut. It reduces food consumption, causes weight loss. And it shows clearly a significant reduction in HbA1c and body weight and improved GI side effects with dose escalation. It's the other way around. You increase the dose, the GI side effects, they start coming down. So, amazing effect, not like the other ones. We had that experience with liraglutide. You up the dose from 0.6 to 1.2, our population doesn't tolerate it. They complain, oh, I'm throwing up, I've got GI problems, I have nausea, I can't tolerate it, doctor. And for weight loss, you need about 3 milligram, not 1.2, 3 milligram of liraglutide for weight loss. But semaglutide is unique. Once weekly, true half-life, 7 days, and by increasing dose, the tolerance of the patient gets better rather than getting worse. So once weekly, semaglutide not only increases insulin secretion, but beta cell responsiveness, suppresses hepatic gluconeogenesis, reduces energy intake and weight loss. And one important thing which I really like to point out is its effect on the lipids. It attenuates the plaque lesion progression in atherosclerotic mouse models, but haven't been shown in humans as yet. But it has been shown clearly. You know about low dense LDL and the large molecule LDL. Anybody? Please show me some hands so I can see some life. No, thank you. Thank you, thank you. Jazakallah, Jazakallah. So you know that low dense molecule is the more therogenic molecule. So that molecule is decreased by semaglutide. So that's a bonus effect. So what they did see in SUSTAIN 1 to 5 and SUSTAIN 7 to 10 studies, that composite and individual endpoints, it clearly led to greater than 1% reduction of HbA1c and majority of cases reduction of more than 5% of body weight in loss in the this population group. The blood pressure significantly, the diastolic one, came lower with semaglutide, both in SUSTAIN 1 and SUSTAIN 10. And I already talked about the lipids and the glucose metabolism. Clearly I have discussed the beta cell responsiveness, the reduction in glucagon, and increased secretion of insulin. Overall, what was seen was in SUSTAIN 6 was 26% reduction in cardiovascular deaths. And it took 45 patients for 2 years to reduce 1% of mortality. This is not insignificant, this is very, very significant. And obviously with HbA1c coming down, it also reduces the weight loss. And there was amazingly 36% reduction in nephropathy. Remember, I told you we've got GLP-1 receptors in the kidneys as well. So I'll come to that immediately, how it does that, very soon. So second part of my talk, very briefly, SGLT2 inhibitors, you already know about them. This is a rare disorder, people knew about it, familial renal glycosuria, a rare inherited disorder in which people lack the gene which is called SGLT2, the sodium glucose co-transporter 2, and they do not have these genes, and these patients have varying degree of glycosuria. They remain asymptomatic, do not become dehydrated, do not become hypoglycemic, and they can exceed up to 125 grams of glucose a day. That led to discovery of SGLT2s, the sodium glucose co-transporter 2 inhibitors. So what they do is they act at SGLT2, and you see SGLT2 is present in S1 segment. 90% of the reabsorption of glucose occurs in the S1 segment. What if we were to block this SGLT2? We would be blocking almost all the reabsorption which is taking place from the kidney. And that reabsorption is not only causing rise in blood glucose by reabsorbing the glucose from the kidney, but also it causes damage to the kidney. Remember, it is the reabsorption of glucose which causes glomerulosclerosis. In normal subject, again important, which I discussed before, the threshold is around 180. But what happens in type 2 diabetics? It moves up to about 240, 250. So they do not excrete, their SGLT2 is upregulated. So what if we were to give SGLT2 inhibitors? They will start excreting more and more glucose, even at levels of around 90 to 100. So we're passing out more glucose. So what consequences do you expect? Obviously, it's going to lead to lowering of the blood glucose, and with the loss of water and salt, it's going to lower your weight as well. So loss doesn't cause, remember, doesn't lead to gross dehydration unless you give them with diuretics. And what will happen if there is loss of glucose? It is sodium. What is SGLT2? Sodium glucose co-transporter. So sodium is also being lost in the kidney. So your blood pressure obviously is going to come down with these inhibitors. What happens at the heart? We know heart utilizes glucose, although in a very small amount, but that small amount is also very important. At any given level, the left ventricle function, if it is not utilizing glucose, results in decreased cardiac efficiency and increased propensity for heart failure. So that is the effect of type 2 diabetes mellitus on the heart. What did the Empire study show in 3-point MACE? That is, cardiovascular death, non-fatal MI, non-fatal stroke. You can see, I no need to elaborate. As the time goes on, this effect was sustained over the time. And what about cardiovascular death? As the time goes on, you can see not only the effect is sustained, but seems to be somewhat getting better. That is, people who are taking SGLT2 had lesser cardiovascular deaths. Lesser cardiovascular deaths. Many people do not know that kidney is an important site of gluconeogenesis. And if you are a type 2 diabetic, this threefold increase in the kidney level in gluconeogenesis. That is, kidneys starts producing through gluconeogenesis both glucose and pouring out into the blood. So liver on the other end and the kidney on the other, they are producing more glucose, and there is increased expression of SGLT2. So if we are able, by giving SGLT2, in not only suppressing the SGLT2 expression, but you also inhibiting this gluconeogenesis. EMPIRE study showed the microvascular outcomes, and I'm not going to take much time. It decreases worsening of nephropathy, and the doubling time of creatinine, it was dramatically reduced. And the rationale is very obvious for using SGLT2s. Briefly touching about the side effects, remember there is slightly increased incidence of infections, but we do not get the feared fungal infections which people talk about, because I was in Pakistan Enterprise Society meeting in Karachi, and one of the speakers, foreign speakers, was saying, well, your Asian population doesn't get these fungal infections. The perennial dangerous necrosis doesn't occur. The 4 years gangrene doesn't occur. And that is because we do ablution. We wash. They do not. And luckily we do not. I personally, once since I have been using SGLT2, I haven't seen any case of 4 years gangrene. And my senior respected colleagues sitting here will shed more light on it, but I haven't seen any case so far. Yes, they do complain of tiredness and obviously postural hypotension, but that is not very marked if you will show them. Briefly, I'm going to touch, which is my topic today, very briefly, going to touch a combination. What about the beautiful semaglutide, which is suppressing appetite, suppressing the gluconeogenesis, decreasing the weight loss, increasing satiety, combined with a drug which further leads to loss of glucose and loss of weight, that is an SGLT2 inhibitor. So semaglutide in combination with SGLT2 inhibitors. So this study is called SUSTAIN 9. And what parameters were seen was HbA1c change from baseline to 30 weeks, body weight, fasting blood glucose, the 7-point self-monitoring of the blood glucose. You look at the lipids, blood pressure, and patients' reported outcomes. And what they looked at after 30 weeks was how many of them achieved a blood HbA1c of less than 7, recommended HbA1c, or ones how many achieved HbA1c of less than 6.5, the AACE recommended goal for HbA1c, and how many of them achieved HbA1c of less than 7, but without any severe hypoglycemia or documented hypoglycemia, with no weight loss, and then look at the weight loss as well. So if you look at the HbA1c after 30 weeks, do I need to speak, or is it obvious? Thank you, Dr. Bhatt, for raising your hand. And show me some sign of life. Come on. Thank you very much. I like the laughter. Right. Look at the HbA1c. 78.7% achieved the target of less than 7. And around 56% achieved the AAC guideline target of less than 6.5 after 30 weeks. Amazing. Fasting glucose, fantastic. And when I remember I was a student, my professor, the late Professor Nasimullah, used to say, F, fix the fasting first. Fix the fasting first. You see, dramatically fixed. Fixed after 30 weeks. Composite endpoints, that is HbA1c of less than 7 without severe hypoglycemia or documented hypoglycemia. About 70% of the patients achieve that target. And with weight loss, about 41.5%. And mind you, these are all, look at the p-values, statistically very significant. Statistically very significant. What about weight loss? Weight loss of more than 5%, almost 50% at end of 30 weeks in sustained aid showed 50%. A weight loss of more than 5%, and almost 15% showed a weight loss of more than 10%. This is not, again, this is significant, clinically significant. So I'm coming to end of my slides. Subcutaneous semaglutide, 1 milligram once weekly, the true once weekly GLP-1 receptor agonist, added on to a stable SGLT2 inhibitor, led to significant and clinically important improvement in glycemic control and reduction in body weight in 30 weeks in patients with uncontrolled type 2 diabetes mellitus, and addition of semaglutide 1 milligram appears to be effective, well-tolerated option for patients who have not met their therapeutic goals despite treatment with the SGLT2 inhibitor. And I'll end my talk here by telling you, well, mind you, in Occidental countries, 30% of their health budget goes into care of complications of diabetes. And what's their health budget? Equal to the budget, total budget of Pakistan, or maybe more. 30% of that budget goes into care of diabetic patients. So, if we are able to control those complications, decrease macro, microvascular complications, maybe we'll reduce the burden of over-hospital admissions and burden on our healthcare system as well. So, I'll end my talk here and thank you all for being very, very patient and very, very good audience. I really enjoyed talking.